say critical level as such really. It depends on each and every patient as well. I try to improve hydration as well as amino acids within the patient with the nutrition point of view, hoping that it will come. That is my first focus on that. But if you need some sort of fluids besides your blood and rest everything else, it could be your synthetic colloids or albumin at that stage for the sake of circuit. When the circuit is thinking, then it could be one of those. Do you have any specific number when you give albumin? When you think of albumin?
No, usually we don't go by a number, but if you feel that a patient is edematous and no, see what happens is that two phase. Initial phase there is a capillary leak and that is causing him more and more edematous. But with the patients on ECMO, the albumin is going to get stuck to the circuit and that is going to cause some drop in albumin levels. So in that case, when we feel that the initial 24 or 48 hours of capillary leaks has been settled down and still albumin is low and that is causing some probably a drop in urine output or making patient more edematous, then we give albumin to them and but not in first 48 hours. Usually we don't give. Only thing is when we prime the circuit of ECMO, usually we put an albumin in that. If the circuit is not albumin coated, then we put an albumin, let it run for 20 minutes to half an hour before we initiate an ECMO. So when we prime the circuit, we put an albumin in the circuit, we let the albumin to run so that the circuit gets coated with some amount of albumin and that will help to decrease the surge kind of reaction.
Venkat?
Yes, I'm ready. I'm ready.
There is a live patient on ECMO in KIMS, so we are trying to get.
Okay.
As soon as it comes, I will stop.
Yeah.
As soon as it's online, I will stop.
Yeah, they are ready. I think we are just calling Prabhakar to do it. But then meanwhile you can start.
Okay. Mechanical circulatory support is a fascinating example of sophistication. One of the component of ECMO circuit is that it is cumbersome, it is too huge, it is complex, it is associated with lot of jerks and sudden terror, sharp episodes. The advantage is that it is flexible. You can use it to your advantage anytime. So in between both these poles, using it for our advantage and being it cumbersome, I will just like to give you an example how mechanical circulatory support has beautified itself and it has perfected itself into a very magnificent piece of craftsmanship. So this is just so that our ECMOs also, as we have seen over a period of time, is getting simpler and better, simpler and better. That is where it will make it more user friendly. Way back in the same time era when ECMO was already established in Europe, mechanical circulatory support started taking an upper hand because heart transplant was getting rare and people were waiting and dying. So these are animal experiments going on. This cart is the heart itself and was connected to the calf and the calf was pulling the heart. So these were the animal experiments. This is again trying to show you that the console, which was previously pneumatically driven, and that round thing here was a sort of a suction pump, suction chamber, which would suck, the diaphragm would move this side and the blood will come in and the diaphragm will push and the blood will get pushed by this suction device, and this big size console was required to maintain the circulation in animal experimentation. This is just a video to show you that finally they were successful in an attempt to see that the patient can be maintained, the animals can be maintained without a heart, but this much big was the unit to match it with the natural heart. Okay. So then they came to, in the 1980s it came to human experiments. In human experiment you can see the entire blue thing in the rear of the patient. This big was the console and the patient was almost bracketed in the console. But that is one of the success. They could maintain the patient and her heart was not working. But this was the situation in 1980s. Then more number picked up. It got miniaturized to half the size, but each one was walking with a cart. Each person whose heart was not able to sustain his hemodynamics were attached to the unit as big as this much size, which was keeping that person alive. Then again, as I said, it was only a LVAD, left ventricular assist device. Then a problem started when in between the ports the right ventricle would give in. So they started up, and the right ventricle would give in. Suddenly managing a right ventricle also with the artificial device was not possible. So they came with an idea of total artificial heart. In this total artificial heart, all the 4 valves are the valves what we have in our rheumatic disease patient. So there are 4 cardiac valves and there are 2 pneumatic chambers. This entire thing has to go inside the thorax of the patient, which is almost to the size of the thorax of the patient. These were the initial few pictures of total artificial heart, 2 pneumatic devices, 4 artificial cardiac valves. Then from extracorporeal, things started going intracorporeal. First it was intra-abdominal, then intrathoracic. Because the chamber device was so big, it did not fit into the size of the chest wall. So that here it came an era of intra-abdominal implantable devices. Then it came to intrathoracic. You can see the X-ray pictures. There were various shades from extracorporeal to intracorporeal to pulsatile to axial flow to pneumatic devices to electrical driven devices, from electrical driven devices to magnetic devices, from rotor flows to axial flows. So there were various eras of transformation in the technology of making the pump engine or the artificial heart and perfecting it to suit with the size of the patient. So these are first generation, second generation, third generation rotor flows and axial flows and pneumatic ones and electrical driven ones and extrathoracic and intrathoracic, again pediatric group and adult group. And in each country in Europe and America, they have various industries who were coming out with their own models, and some had some features in plus and some features in minus. So there was a huge collection of various types of devices developed by various industries in various countries across Europe and America. So these are the various examples and the names of all these things, devices, and this is the comparison and the studies of how many devices in each patient and how do they monitor it. The most tedious part you would like to listen to that patient on artificial device has to go for PT monitoring every evening, because next day morning he would be drop dead because if the blood coagulates. So that is the requirement. We fail to get a PT done for our valve replacement patient every month. Their PT is required every evening. They have to go on the computer to understand the hemodynamics and the flow velocities, because if the pump is moving with the speed and it is pushing the blood, it will make the RV empty in short time. So every evening they have to stand in front of the computer. They will analyze their flows and tell him to decrease the RPM or increase the RPM of the artificial device, so as to remain in coherent with the volume, intravascular volume of the patient. So things were not easy, they were tedious, but you try to understand from where they are marched in a short period. This is again an extracorporeal, pneumatic, pediatric, Berlin heart thoracotomy device. You can see here, this is only an LVAD. This child has a myocarditis and was not maintained himself. So this is the way they could sustain it. The 2 tubes are outside the body, or infection chances, and this pump has driven, these tubes are going to a pneumatic pump, and the pump is driving the blood in and out, and this is a pneumatic chamber. So this is how they progressed. This is the biventricular extracorporeal pneumatic assist device for right ventricle and a left ventricular support. After the patient improved out of myocarditis, the patient is like this. These are few examples of similar example. This is extracorporeal cannulations of a biventricular assist device. Then as the thing progressed from pneumatic to electrical system, they were connected by a cable outside where there was an electrical system or a battery system to support the pump, and the pump became intracorporeal biventricular supports. Okay, this is just to show you an example. When the thing gets more compact, this is a small girl who is connected to the computer. As I said, you can analyze the cardiac status or the hemodynamic status of the patient every time, but they are stick to a console. This is just an example to show you that this is how they were kept alive and had some quality of life with progress. This is somewhere in 1990s. Then these are the various sizes of extracorporeal devices, the various cannulas in the aorta. Then this was the complete unit required. This is like the pneumatic system. Then it got miniaturized to a size of a briefcase. Then these are the two pneumatic pumps put on a wheel, and the patient used to carry them with them. From a big console bigger than the size of the Almara, the thing got modified and compacted to the size of the briefcase. But they require a console, a computer, and a pneumatic chamber connected by tubings, which is going inside the intrathoracic pneumatic pump chambers, which is sucking and pumping blood. This is how the patient would move around. At least the patient is mobile and he carries himself with a pneumatic chamber, carrying a briefcase all the time. This is a gathering of all such patients during physiotherapy. This is, they have become more ambulatory. They are outside the ICU. They are outside the still in hospital, but at least in the outside the hospital premises. And then they are there. The patients are exercising. They are alive with this system, which has become more compact, like a size of your laptop bag. Now they are outside the hospital, but still stuck to all these things. Then came, this was a biventricular device, total artificial heart, 2 pumps going to the chest wall. This was the size of the device, which was intrathoracic. Then came the era of electrical system. In electrical system, this was a compact thing. As automobile industry is on the full heights of excellence, for perfecting a cardiac or a blood chamber and a blood pump was not very difficult for them. They kept on improving things. Now the cardiac pump reduced to the size of the palm. So this is how the things have progressed somewhere in 1995. And then one was the efferent and one was the afferent. The blood was sucked in from the apex of the AV cavity and was put to the artificial chamber and was returned back to the aorta. Therefore this was acting like an isolated left ventricle. And this is a photograph of the motor, which is a magnetic driven motor. The blood is not in contact with the axle anymore, and the magnet drives the motor, thereby pumping the blood. And this is what is the X-ray picture, and finally this is a picture of implantation, the position of the sutures on the chest, and these are the various components. This is the position, how it look like. This is, you see the heart, the machine is put under the heart and the abdominal cavity. It is taking the blood from the LV apex here and is returning the blood via tube, which goes back to the aorta. That is, this is how it is bypassing this. And the entire machinery is connected to the cable. The cable comes out percutaneously and is attached to the battery and battery to the console. So the patient moves around with the abdominal belt where the battery and these things are connected. But it is much better than the big console what you see. These are various examples that how it is in there. Then it further got modified, and the size of the biventricular elevated assist device got reduced to the size of the thumb. The Jarvik device, the Jarvik 2000, which was only from the size of the fist, it got reduced to the size of the thumb, and that is what is the Jarvik device. This was placed at the apex of the left ventricle, and the efferent was the left ventricle itself. The efferent was just tunneled to the aorta, descending aorta. So this was the miniaturized size of a left ventricular assist device. And then some similar lines, other companies also started making their pumps in the similar fashion. So this was just to show you the march of the event from year to year to year to year